Hello, I'm Dr. Amelia Carter, a family physician with more than 10 years of experience caring for adults over 50, people who have worked hard their whole lives, raised families, and now deserve to feel strong, steady, and protected in the years ahead. Right now, millions of older adults are taking medications every day that could be quietly putting strain on their hearts. These are not rare or experimental drugs. They are common, everyday medications, many available over the counter, many prescribed routinely by doctors. They sit in medicine cabinets across the country, taken for pain, heartburn, infections, sleep, or other very real discomforts. In recent years, cardiac surgeons and cardiologists have started raising serious concerns. They're seeing patterns in their clinics and operating rooms that are hard to ignore. Hearts that should be relatively healthy for a patient's age showing unexpected damage, inflammation markers elevated, heart muscle weakened, irregular rhythms appearing without clear explanation. When they look back at medical histories, one group of medications keeps appearing again and again. The research is now catching up to what these specialists have been observing firsthand. Major studies from institutions like the American Heart Association, the European Heart Journal, Johns Hopkins, the Cleveland Clinic, and large-scale analyses in journals such as the Lancet, JAMA, and BMJ have confirmed measurable cardiovascular risks with certain widely used drugs. We're not talking about extremely rare side effects that happen to 1 in a million. We're talking about risks that affect a significant percentage of older users, some studies showing 20 to 50% or higher increases in serious heart events like heart attack, heart failure, stroke, or dangerous arrhythmias. The most concerning part is that many people have no idea they may be at increased risk. They take these medications because they help with real pain or symptoms, and they trust that if there were danger, someone would have warned them. But there is one class of drug that cardiac specialists and recent research point to as the most frequent and serious concern for older hearts. The evidence on this particular medication is so consistent and concerning that some experts have called for stronger warnings specifically for adults over 50. A large meta-analysis involving hundreds of thousands of patients found significantly elevated risks of heart attack, heart failure hospitalization, and stroke with regular use. Before we reveal that number one medication, I want to walk you through the full list calmly and clearly so you understand the complete picture and can make informed decisions about what might be affecting your heart right now. Before we begin, if this is already feeling close to home, if you or someone you love takes any of these common medications, please take a moment right now to drop a quick comment below, your age, and where you're watching from today. I read every single comment, and they help me understand what matters most to you and shape future conversations to support our community of caring adults over 50. If what you've just heard is already feeling close to home, if you or someone you love takes any common medications for pain, heartburn, sleep, or other everyday issues, and you're wondering about heart health, please tap that like button right now. It helps this calm, caring conversation reach more adults over 50 who might be quietly asking the same questions. If you haven't already, hit subscribe and turn on notifications so you never miss these gentle, evidence-based talks designed especially for people who want to stay proactive, informed, and protected as the years go by. And most importantly, leave a quick comment below, your age, and where you're watching from today. Maybe just 62, watching from Texas, or 58, here in Florida, whatever feels right. Your thoughts help me understand who's here with us, shape future videos around what truly matters to you, and build this warm, supportive community where we all look out for each other's well-being. I read every single comment, and they mean a great deal to me. Let me share a story from my own practice that illustrates why this topic matters so deeply to me. Robert was a 68-year-old patient who had managed arthritis in his knees and lower back for years with over-the-counter ibuprofen. He took it most days, sometimes 2 or 3 times, to keep moving, stay active with his grandchildren, and avoid feeling old. He felt fine overall, no chest pain, no major shortness of breath, just the usual aches that come with age. Then one afternoon he suddenly felt extremely fatigued. His legs swelled noticeably, and he had trouble breathing when lying flat. We rushed him to the hospital where tests showed new-onset heart failure, fluid buildup around his heart and lungs, weakened pumping function. When we reviewed his history, the regular NSAID use stood out as a major contributing factor. He looked at me with quiet shock and said, "I never imagined a pill I bought at the store could do this to my heart. I wish someone had told me sooner." Stories like Robert's are becoming more common, and they're exactly why cardiac surgeons, cardiologists, and researchers are raising the alarm. In operating rooms and clinics, specialists are seeing older hearts that show unexpected damage, elevated inflammation markers, weakened muscle, irregular rhythms, and sudden events that seem out of proportion to the patient's age or other risks. When they trace back the medication history, certain commonly prescribed or over-the-counter drugs appear repeatedly. The research now supports what these clinicians have been observing. Major studies from the American Heart Association, European Heart Journal, JAMA Cardiology, the Lancet, and large meta-analyses involving hundreds of thousands of patients have documented real cardiovascular risks with some of the most widely used medications in adults over 50. These are not extremely rare side effects. They are significant increases in risk that affect a meaningful percentage of regular users. Some studies show 20 to 50% or higher increases in heart attack, heart failure hospitalization, stroke, or dangerous arrhythmias, especially with longer-term or higher-dose use. The most concerning aspect is how silent and gradual this damage can be. Many people feel perfectly fine while taking these medications until a tipping point is reached and symptoms appear suddenly or a serious event occurs. That delay is what makes awareness so important. Today, we're going to walk through 5 of the most commonly discussed medication classes that recent evidence has linked to increased heart risks in older adults. We'll look at each one calmly and clearly, what the studies show, why the risk happens, who is most vulnerable, and most importantly, safer alternatives and steps you can take. These medications were prescribed or recommended for very real reasons: pain relief, acid reflux, infections, sleep issues, or blood sugar control, and they help millions of people. The goal is not to create fear, but to give you accurate information so you can have informed conversations with your doctor. Many risks are dose and duration dependent. Short-term or occasional use is often much safer, and there are almost always gentler options available. Let me start with a medication class that surprises many people when they hear about the potential heart concerns certain sleep aids, particularly the so-called Z drugs like zolpidem, Ambien, Zaleplon, Sonata, and asalpaquone, Lunesta, as well as older benzodiazepines such as temazepam, Restoril, lorazepam, Ativan, and diazepam, Valium. Sleep troubles are incredibly common after 50 or 60. Nearly half of older adults report difficulty falling asleep, staying asleep, or waking too early. It's completely understandable to reach for something that promises rest. These medications can be very helpful for short-term use, especially during stressful periods or acute insomnia. The concern arises when they're taken regularly or long-term, as many older adults end up doing. Recent studies have raised important flags about cardiovascular risks with these drugs in people over 50. A large analysis published in BMJ Open looked at over 30,000 patients using hypnotic sleep aids like the Z drugs. Researchers found an association with significantly higher overall mortality compared to similar people not taking them, and cardiovascular events were among the leading causes of those excess deaths. Other research in the journal Sleep has linked benzodiazepine use in older adults to increased cardiovascular mortality, particularly from heart-related causes. Several mechanisms may explain this. These medications can suppress breathing slightly during sleep, something called respiratory depression, which can worsen undiagnosed or borderline sleep apnea. Sleep apnea itself is a major risk factor for high blood pressure, heart strain, atrial fibrillation, and heart failure. By making breathing pauses longer or more frequent, these drugs can indirectly add stress to the heart over time. They're also associated with next-day grogginess, dizziness, and impaired balance, which dramatically increases fall risk in older adults. Falls often lead to hospitalization, fractures, or immobility, and the physical and emotional stress of those events can trigger heart attacks, arrhythmias, or worsening heart failure in vulnerable people. The evidence is strongest for long-term or frequent use. Occasional, short-term use, a few days or weeks, generally carries much lower risk. The FDA has added warnings to these medications about risks in older adults, including falls, cognitive effects, and complex sleep behaviors. Safer, non-drug approaches often work better for chronic insomnia in the long run. Cognitive behavioral therapy for insomnia, CBT-I, a structured program that addresses thoughts and habits keeping you awake, has stronger evidence for lasting improvement than pills, with no cardiac risks. Many communities and online programs now offer CBT-I. Simple sleep hygiene helps enormously, consistent bed/wake times, limiting screens an hour before bed, keeping the bedroom cool and dark, avoiding caffeine after noon, and getting morning light exposure. For occasional help, low-dose melatonin, 0.5 to 3 milligrams, appears much safer for heart health and has supportive evidence in older adults. If a prescription sleep aid is truly needed, starting with the lowest dose for the shortest time possible minimizes any potential concerns. If you're currently taking one of these medications regularly for sleep, please don't stop suddenly on your own. Talk to your doctor. They can help taper safely if needed and guide you toward gentler, more sustainable options. This isn't about creating worry. It's about giving you the full picture so you can protect your heart while still getting the rest you deserve. Let's move to number 4, certain older diabetes medications that have come under scrutiny for heart risks. Module 5, Drug 4, Sulfonylureas, older diabetes medications. Now let's move to a group of medications that many older adults with type 2 diabetes have relied on for years, sulfonylureas. These include drugs like glipizide, glucotrol, glyburide, diabeta or micronase, glympiride, Amaryl, and others. They work by stimulating the pancreas to release more insulin, which helps lower blood sugar. For many people, these medications have been a trusted part of diabetes management, especially when newer options weren't yet available or weren't affordable. The concern arises because recent research has shown that sulfonylureas carry a higher cardiovascular risk compared to some other diabetes treatments, particularly in adults over 50 or 60, who often have other heart risk factors already present. A large study published in Circulation, Cardiovascular Quality and Outcomes followed over 250,000 diabetic patients and found that those using sulfonylureas had about a 20% higher risk of cardiovascular death compared to those using metformin alone. Other analyses in diabetes care and similar journals have shown increased rates of heart attack and hospitalization for heart failure in patients on these drugs, especially glyburide and longer-acting agents. Several mechanisms may contribute. Sulfonylureas can sometimes cause episodes of low blood sugar, hypoglycemia, which triggers stress hormones like adrenaline and cortisol. These hormones put extra strain on the heart, raising heart rate, blood pressure, and oxygen demand, which can be particularly risky for older adults with underlying coronary disease or weakened heart muscle. There's also evidence that some sulfonylureas may affect potassium channels in heart cells, potentially making the heart more susceptible to irregular rhythms during times of stress or low sugar. Over time, repeated hypoglycemic episodes or the way these drugs push insulin release may contribute to a less favorable metabolic environment for the heart. The contrast with newer diabetes medications is striking. Drugs like SGLT2 inhibitors, empagliflozin/Jardiance, dapagliflozin/Farxiga, and GLP-1 receptor agonists, semaglutide/Ozempic, liraglutide/Victoza, have large clinical trials showing they actually reduce heart failure hospitalizations, cardiovascular death, and major heart events in people with type 2 diabetes. Many guidelines now recommend these newer classes first line for patients with established heart disease or high cardiovascular risk. If you're currently taking a sulfonylurea, please don't stop it on your own. Sudden changes in diabetes medication can cause blood sugar swings that are dangerous. Instead, bring this up at your next appointment with your primary doctor or endocrinologist. They can review your overall heart risk, kidney function, and blood sugar control, then consider whether switching to a heart protective alternative or adding one makes sense for you. Many patients transition smoothly and feel better with the newer options, often with fewer lows and added heart benefits. This isn't about fear, it's about giving you the most up-to-date information so you can have the best possible conversation with your doctor. Diabetes management today is more personalized than ever, and your heart health is a key part of that picture. Let me share a quick story that highlights why this next one catches so many people off guard. Susan was a healthy, active 62-year-old who developed a urinary tract infection. Her doctor prescribed a short course of ciprofloxacin, a common fluoroquinolone antibiotic, and she felt better quickly, so she finished the prescription. A few weeks later, she started having unusual back and abdominal discomfort. An ultrasound revealed a small abdominal aortic aneurysm that had grown and needed monitoring. When we reviewed her recent history, the fluoroquinolone stood out. She said, "I had no idea an antibiotic could affect my blood vessels like that. It was just for a simple infection." Fluoroquinolones, including ciprofloxacin, Cipro, levofloxacin, Levaquin, moxifloxacin, Avelox, and others, are powerful antibiotics that are very effective for certain bacterial infections like complicated urinary tract infections, pneumonia, or severe sinusitis. They save lives when truly needed. The concern for older adults comes from well-documented links to serious cardiovascular complications, particularly with the aorta and heart rhythm. A major study published in the Journal of the American College of Cardiology analyzed data from over 7 million patients and found that current use of fluoroquinolones was associated with a 66% increased risk of aortic aneurysm or dissection, a dangerous bulge or tear in the main artery, leaving the heart. This risk was most pronounced in adults over 65 and persisted for up to 60 days after stopping the medication. Aortic dissection is often life-threatening, and while it's still relatively rare, the relative increase is significant enough that the FDA has issued multiple warnings. These drugs can also cause QT prolongation, a change in the heart's electrical activity that increases the risk of dangerous arrhythmias like torsades de pointes. A New England Journal of Medicine study confirmed elevated risk of serious cardiac arrhythmias in older patients taking fluoroquinolones, especially those with pre-existing heart conditions or on other QT prolonging medications. The mechanisms involve effects on connective tissue. Fluoroquinolones can weaken collagen in vessel walls, increasing aneurysm risk, and direct impact on cardiac ion channels, leading to rhythm disturbances. The risk is highest with systemic use and in people over 60, those with hypertension, or a history of vascular disease. The good news, these antibiotics are not first line for most common infections anymore. Safer alternatives like amoxicillin, nitrofurantoin, trimethoprim-sulfamethoxazole, or cephalexin are usually just as effective for uncomplicated UTIs, sinus infections, or skin infections and do not carry the same cardiovascular concerns. The FDA now recommends reserving fluoroquinolones for situations where no safer option exists. If your doctor prescribes one, it's completely reasonable and wise to ask, is there a safer antibiotic that would work for this infection? Most physicians appreciate the question, especially for older patients. If a fluoroquinolone is truly necessary, they can monitor closely and discuss any personal risk factors. Please never stop or change an antibiotic on your own mid-course. Always finish the prescribed duration unless your doctor advises otherwise to avoid resistance or incomplete treatment. But do bring up any concerns before starting. This is about empowering you with information so you can advocate for the safest care possible. Let's continue to number 2, proton pump inhibitors, which are among the most commonly taken medications worldwide. Let's move to a medication class that many older adults take for years without a second thought, proton pump inhibitors, commonly known as PPIs. These include drugs like omeprazole, Prilosec, esomeprazole, Nexium, lansoprazole, Prevacid, pantoprazole, Protonix, and others. They're extremely effective at reducing stomach acid and are widely prescribed or taken over the counter for acid reflux, heartburn, GERD, or to protect the stomach during long-term use of other medications. For short-term use, say, a few weeks to a couple of months, PPIs are generally very safe and helpful. The concern arises when they're taken regularly for years, which is common in adults over 50 who have chronic reflux or Barrett's esophagus, or who stay on them just in case. Several large studies have raised questions about cardiovascular risks with long-term PPI use. A major analysis published in PLOS One examined data from nearly 3 million patients and found that PPI users had a 16 to 21% higher risk of heart attack compared to similar people not taking these drugs. Another study from Stanford University looking at patients with known coronary artery disease found that long-term PPI use was associated with roughly double the risk of cardiovascular death. The proposed mechanism centers on nitric oxide. PPIs appear to reduce the production of nitric oxide in the cells lining your blood vessels. Nitric oxide is essential for keeping arteries relaxed, preventing clots, and reducing inflammation. When levels drop, arteries can become stiffer, blood pressure may rise slightly, and the risk of clotting or plaque instability can increase over time. It's important to emphasize that these risks are mostly linked to chronic, daily use, not occasional or short courses. Many people can safely taper off PPIs or switch to alternatives once their symptoms are under control. Safer options often include lifestyle changes, eating smaller meals, avoiding triggers, spicy/fatty foods, caffeine, alcohol, not eating within 2 to 3 hours of bedtime, elevating the head of the bed 6 inches, and losing even a modest amount of weight if needed. These steps dramatically reduce reflux for many. Over-the-counter H2 blockers like famotidine, Pepcid, or ranitidine alternatives, these reduce acid differently and appear to have a much lower, if any, association with heart risks. Antacids, Tums, Rolaids for occasional symptoms. If you're currently taking a PPI long-term, please don't stop suddenly without talking to your doctor. Acid rebound can be uncomfortable. Instead, bring it up at your next visit. I've been on this for X years. Can we try tapering or switching to something else? Many physicians are happy to reassess and guide a safe transition. This is about giving you the information you need to have a good conversation with your healthcare team, not about creating unnecessary worry. Most people who need acid suppression can find a heart-friendlier way to manage it. Let's continue to the number one medication that cardiac specialists and recent research highlight as the most significant concern for older adults' hearts. Now we arrive at the medication class that cardiac surgeons, cardiologists, and recent large-scale research point to as the most significant and frequent concern for the hearts of older adults, non-steroidal anti-inflammatory drugs, or NSAIDs. These include Ibuprofen, Advil, Motrin, Naproxen, Aleve, Diclofenac, Voltaren, Celecoxib, Celebrex, and others, both over-the-counter and prescription versions. NSAIDs are incredibly effective for pain relief, reducing inflammation in conditions like arthritis, back pain, headaches, or post-injury swelling. They're taken by millions every day, often long-term for chronic pain. For younger people or occasional short-term use, the cardiovascular risks are generally low. But for adults over 50, especially those with hypertension, existing heart disease, diabetes, or kidney issues, the risks become much more substantial with regular or higher dose use. A comprehensive meta-analysis published in the Lancet examined data from over 350,000 patients across multiple trials and found that high-dose NSAID use increased the risk of major cardiovascular events, heart attack, stroke, heart failure, by about 1/3 overall. Specific drugs showed even higher relative risks. Ibuprofen was linked to a 44% increase, Diclofenac to 41%, and Celecoxib to 37%. Other large studies, including a Danish nationwide analysis of over 1 million patients, showed that even short-term NSAID use, as little as 1 week, was associated with increased cardiovascular risk in older adults, with the dangers starting to rise almost immediately. The mechanisms are well understood and involve several pathways. NSAIDs block enzymes, COX-1 and COX-2, that produce prostaglandins, substances that help protect the kidneys, maintain balanced blood pressure, and prevent excessive clotting. This leads to sodium and fluid retention, which raises blood pressure and puts extra strain on the heart, particularly risky if heart function is already borderline. They can reduce kidney blood flow, worsening fluid balance, and sometimes triggering or exacerbating heart failure. In people with existing plaque, NSAIDs may destabilize plaques or promote clotting, increasing the chance of heart attack or stroke. The risk is dose-dependent and duration-dependent. Higher doses and longer continuous use carry the greatest concern. People with a history of heart failure, recent heart attack, or uncontrolled hypertension face the highest risk, which is why many guidelines now advise avoiding NSAIDs entirely in those groups when possible. Safer alternatives for chronic pain include acetaminophen, Tylenol. As first line, it does not carry the same cardiovascular risks, though watch liver dose limits. Topical NSAIDs, gels or creams like Voltaren gel, they deliver relief directly to the area with much lower systemic absorption and appear safer for the heart. Physical therapy, gentle exercise, heat/ice, acupuncture, or weight management. Many patients reduce or eliminate oral pain meds with these. For inflammatory conditions like arthritis, low-dose corticosteroids, short-term, or disease-modifying drugs under rheumatologist guidance. If you're currently taking an NSAID regularly, especially daily or multiple times a day, please do not stop abruptly without talking to your doctor. Sudden withdrawal can cause rebound pain or other issues, and they can help transition you safely to a gentler option. Bring it up at your next visit. I've been using Ibuprofen/Naproxen for my arthritis. Should we explore alternatives given my age and heart health? This conversation is about empowerment and protection, not fear. Many people use NSAIDs safely for short periods, and for those who need ongoing pain relief, there are almost always heart-friendlier paths forward. We've covered the 5 medication classes that research and specialists have flagged as carrying notable cardiovascular risks in older adults. The key takeaway is awareness. Most of these risks are preventable or manageable with informed choices and good communication with your healthcare team. You're taking a powerful step right now by learning this. You're someone who cares about your heart, takes responsibility for your health, and stays open to what the evidence shows. That's a beautiful thing. Be gentle with yourself as you think about next steps, whether it's a quick note to discuss with your doctor or simply feeling more confident that you're informed. Thank you from the bottom of my heart for spending this time with me. I'm truly grateful you're here, listening, and caring enough about your well-being to reflect on these things. You deserve to feel strong, steady, and protected. Take good care of your heart, talk to your doctor when you're ready, and know that small, thoughtful changes can make a real difference. Until next time, be kind to yourself. You're doing wonderfully. Take care.